So my name is Rana. I'm one of the regional anesthesia fellows at St. Paul's Hospital here in Vancouver, and I'm about, or just over halfway through my fellowship now. And I'm going to be talking today about regional anesthesia for upper limb surgery. Now, this is a fairly large topic to cover, so I've selected what I think to be the most useful and commonly used blocks for surgery of the upper limb, but I'm happy to discuss anything that I haven't covered after the presentation. So in terms of some of the objectives, we're just going to quickly review the innervation of the upper extremity and the anatomy of the brachial plexus. We're going to look at the anatomy and sonoanatomy of the brachial plexus, particularly the interscalene groove, the supraclavicular fossa, and the infraclavicular fossa. I'm not actually going to be going through the axillary nerve block today. We'll sort of throughout the presentation discuss indications and limitations of the block at these various anatomic locations, and we'll have a look at some ultrasound images and videos to demonstrate the blocks. So on the left-hand side of the screen, there's sort of an image of the cutaneous sensory distribution of the upper limb. And the osteotomes on the right-hand side of the screen. So as we all know, the innervation of the upper limb is predominantly from the brachial plexus. The cervical plexus does innervate the skin that overlies part of the shoulder, and you can see that in the purple color here labeled supraclavicular nerve. And the medial part of the proximal arm as well is covered by the intercostal brachial nerve, which is not part of the brachial plexus and comes from T2. But predominant innervation is from the brachial plexus. So again, just some review. The brachial plexus is generally formed by the ventral rami of C5 to T1 nerve roots. And there can be some anatomic variation in that there may be some additional contribution from one or more cranial or up to two caudal levels as well, which can become clinically relevant to how the shoulder or the medial regions of the arm might be innervated. And along its course from proximal to distal, the brachial plexus passes through sort of four distinct topographical areas that we can use to block the brachial plexus. The interscalene gap is where we perform the interscalene block, targeting the nerve roots of the brachial plexus. The posterior triangle of the neck is where we would traditionally do our supraclavicular block, targeting the distal trunks and the proximal divisions. The infraclavicular block targets the cords, and the axillary block, the terminal branches. So just before proceeding to talk about the various blocks, I just wanted to include a quick slide on block preparation, just to remind ourselves that all of our procedures should be performed in a monitored area with reliable IV access, emergency drugs, including intralipid, as well as oxygen available. And a pre-procedure timeout is always a useful way to verify consent, verify the correct side to be blocked, and identify any potential contraindications. So starting off with the interscalene brachial plexus block, this particular block targets the C5, 6, and C7 nerve roots of the brachial plexus between the anterior and middle scalene muscles. So as we know, C5 and C6 come together to form the superior trunk, and C7 forms the middle trunk of the brachial plexus. So the inferior trunk is usually spared with this block, and because of that, it's really only well suited for procedures involving the shoulder and the upper arm. So that can be things like shoulder arthroplasties, arthroscopy and rotator cuff repairs, humerus fractures, sort of as examples. Now looking a bit more carefully at the anatomy at the interscalene level, above the clavicle, we can see that the brachial plexus is seen lateral and posterior to the carotid artery and the internal jugular vein, and situated between the anterior scalene muscle and the middle scalene muscle. And I just wanted to make a note that the phrenic nerve that you can see running along the surface of the anterior scaling muscle is in very close proximity to the brachial plexus at this level. And so it's essentially almost always blocked with this approach with the volumes of local anesthetic that we use here. So it's one thing to think about when you have a patient who has baseline respiratory compromise. This particular block may not be suitable for that patient. This is a cross-sectional view and the associated ultrasound image on the right here. And you can sort of see that classic traffic light sign of the C5, C6, and C7 nerve roots situated between the anterior and the middle scaling muscle. In this particular image, you can also see the transverse process of C7, sort of an L-shaped transverse process here. So that's the one tubercle, and it's usually very closely associated with the location of the vertebral artery as well. So it's very important in this area to scan very carefully and use color Doppler to locate all of the vasculature and particularly avoid things like the vertebral artery prior to needling. The positioning for this block is usually fairly simple. It's mostly done supine with the head facing away from you. A slight elevation of the head of the bed is often comfortable for the patient, and it also allows for better drainage of the neck veins so that they're less prominent. Usually we take an in-plane approach from the lateral side of the probe, and so in some cases a semilateral or lateral position may be more ergonomic for the operator, especially when inserting a perineural catheter. It gives your hand a bit more space. With respect to landmarking, the probe is usually placed on the anterolateral neck behind the clavicular head of the sternocleidomastoid muscle, as you can see here, about 1 to 2 centimeters above the clavicle. The target's quite superficial, so we usually use a high frequency linear transducer as well as a shorter block needle. So for example, a 50 millimeter echogenic block needle as opposed to an 80 millimeter block needle. The volumes that we typically use are about 10 to 15 milliliters of local anesthetic. And the choice of local anesthetic really depends on your goals for onset, the duration of action, and the density of the block. And we'll also see in a moment, there are actually sort of two different practices with respect to where exactly the local anesthetic is deposited for this block. The classical approach is to place local anesthetic within the brachial plexus sheath. Alternatively, it can be placed just outside the sheath between the plexus and the middle scaling muscle, which is a more conservative approach, but it can achieve very similar results and reduce the risk of nerve injury. The caveat to that would be when you're inserting a perineural catheter, you really do want to be in that, you want to pierce the brachial plexus sheath. Dynamic scanning really does help with identifying the correct sonata anatomy, and I personally like to start with finding a supraclavicular view of the brachial plexus just above the clavicle. So here you can see your subclavian artery with the brachial plexus situated next to the subclavian artery. You have your lateral side on the right and your medial on the left. And essentially you can follow the plexus up cranially until you're able to see sort of this traffic light orientation of the nerve roots between the anterior and middle scaling muscles. Now, obviously anatomy varies and it's not always this obvious, which is why dynamic scanning can help you identify your structures a lot more easily. And this is just a video of that. So you can see your intrascaling groove. The probe is moving inferiorly just above the clavicle. In the supraclavicular view, you have your brachial plexus and your subclavian artery. And scanning back up, you can follow your brachial plexus up to the interscaling groove, where you can see your C5, C6, and C7 nerve roots in between your scaling muscles. I'm actually going to skip over this video, I think, for the time being, just for the sake of time, but I just quickly wanted to point out that with the interscaling block, we ideally want to deposit the local anesthetic between the C5 and C6 nerve roots, or outside of the sheath right next to it. And so in this particular image, we can probably say that that's C5, this is C6, and sort of a more bifid appearance, and C7 further down here, but we're not entirely sure. And when you have a patient who's got more difficult anatomy, you really should use dynamic scanning in order to confirm for yourself that those are the actual roots that you're looking for. So if we scan cranially, we can see we can confirm that by watching the nerve roots sort of disappear into the transverse process of their respective vertebra. And if there's time at the end of the presentation, I'm happy to show this a little bit of a longer video. So I mentioned that there are a couple of different spread patterns that one can aim to achieve. So classically, again, as I mentioned, the brachial plexus is pierced between C5 and C6. So you can see that the left side, in this case, is lateral. And so you're going to see the needle of the operator approaching the brachial plexus through the middle scaling muscle, aiming for that C5, C6 space. And in this particular video, they do pierce the brachial plexus sheath. And to me, this particular video looks a bit aggressive in terms of needling, but just kind of using gentle pressure and corkscrewing your needle through that sheath works as well to sort of try and avoid paresthesia. So as you can see, the local anesthetic is pushing the nerve roots far away from each other and sort of spreading circumferentially around the nerve roots. And again, this particular provider decides to sort of reposition the needle below and above. I'm not so sure that's necessary. I think probably injecting the volume that we do in that one space will allow you to get adequate spread without risking further paresthesias or potential nerve injury. So you can see that spread all around the brachial plexus there. And this is the alternative sort of spread pattern that I was referring to. In this case, the right side of the screen is lateral, and you can see the C5 and C6 nerve roots in between your scaling muscles. The needle is taking a trajectory through the middle scaling muscle to sort of situate the tip of the needle just beside that C5, C6 nerve root without piercing the brachial plexus. And we'll see in a moment that the spread is sort of, we get this nice linear spread all along the one side of the brachial plexus. And the idea is that the local anesthetic placed outside the sheath can diffuse across and anesthetize the nerve structures. So this way, the risk of nerve injury can be minimized by staying outside the sheath. Now, I personally haven't used this this method too many times, and anecdotally, I have heard that it occasionally can fail. So checking the block, 15 minutes after performing it would be useful to know whether or not you need to deposit some additional local anesthetic. And again, the perineural catheters placed with this method likely not very effective, and you do need to pierce through the brachial plexus sheath. A few things to think about with respect to the brachial plexus block. Like I mentioned earlier, it is a pretty highly vascular area, so making sure that we're aware of our vascular structures prior to needling and knowing exactly where they are in our needle trajectory is very important. We saw the vertebral artery in that one image, but there are other vessels along the way as well. We touched on the phrenic nerve block. the sort of the location of the phrenic nerve running along the superficial aspect of the anterior scaling muscle, so close to the brachial plexus, means that it's very commonly blocked with as little as 10 milliliters of local anesthetic. So patient selection becomes quite important when deciding to do this block. The other thing to note is that the dorsal scapular and long thoracic nerves often pass through the body of the middle scaling muscle, and they can be at risk for needle trauma. And they tend to be run somewhat deeper at the interscalene level, so keeping the needle trajectory fairly superficial until the plexus is reached is usually advised, or using using nerve stimulation. So this video just briefly shows the brachial plexus. This is the anterior scaling muscle, and you can see the video is already showing it with an arrow there, but the phrenic nerve coursing over the superficial aspect of the anterior scaling muscle, just showing the proximity to the brachial plexus at this level. And over on to the right side of the screen, you can see the dorsal scapular and long thoracic nerves coursing through the body of the middle scaling muscle. So those are things to watch out for. So moving on to the supraclavicular block, and I apologize for the fast pace. There's quite a bit to cover, so please feel free to stop me at any point if something is unclear, if you have any questions. But moving on to the supraclavicular brachial plexus block. At this level, we're mainly targeting the trunks of the brachial plexus, cephalad to the clavicle. It's usually used for surgery of the upper limb distal to the shoulder, and sometimes additional blockade of the suprascapular nerve might be needed for shoulder surgery. It's traditionally been, or in the past, been sort of referred to as the spinal of the upper limb for how complete the coverage can be. And just to note that theoretically, the intercostobrachial area of the upper limb would not be covered with this block. So indications for upper limb distal to the shoulder would be things like, biceps tendon repairs, elbow surgery, forearm procedures like fractures or AV fistulas, any procedures of the wrist and hand, and usually with a single shot technique. It is a fairly shallow target, and it's a pretty highly mobile area, and it makes it unfavorable for catheter technique. They do tend to be at significant risk for displacement. So alternatively, the catheters should be placed intraclavicularly. Positioning is the same as essentially for an interscalene block. It's usually supine with the head of the bed elevated and the head turned away. The arm is placed by the patient's side. If you want to put a bump under the scapula, you can. The probe is usually placed in the transverse plane, immediately proximal to the clavicle. And if you tilt the probe caudally into the chest, you can obtain a good view of the cross-sectional view of the subclavian artery. So you see the subclavian artery there, and you see the brachial plexus as a collection of sort of hypoechoic, oval, round structures, posterior and superficial to the subclavian artery. And if you gently rotate your probe, the goal would be to situate the first rib underneath the subclavian artery. So you can see the lining of the pleura here with lung tissue deep to it, and that would be the first rib. So the goal would be to create sort of that corner pocket with the artery, the brachial plexus, and the first rib as a safe, sort of a safety guard for your initial injection. And that's what we call the corner pocket. Again, shallow structure, so typically a higher frequency transducer, linear transducer would be used. Long or short block needle probably doesn't make a difference. We usually use an 80 millimeter epigenic needle for this block, especially if the brachial plexus happens to have a long tail and you want to start a bit more laterally and hydrodissect your way through the pocket, a longer needle would be useful. Typical volumes of local anesthetic, about 20 to 25 mils, and similar sort of considerations for deciding what type of local anesthetic to use. And just to remember that because of the fact that it is very shallow, we have to be pretty aware of our needle and our needle tip and make sure that our needle insertion is equally shallow. So this is just another ultrasound image of the supraclavicular, sort of our supraclavicular targets of the brachial plexus and a cartoon rendition of that. So again, the subclavian artery, the pleura, and the first rib that's creating that corner pocket that we want to target. And if you look closely, you can sort of see the superior trunk, the middle trunk here, and the inferior trunk of the brachial plexus. In this particular image, you can see the dorsal scapular artery within that brachial plexus sheath, and there are other arteries along the way. So again, a highly vascular area, and we should be using color Doppler. I mean, when you sort of look at it, it looks very similar to the nervous structures in the fascicles, so it's very important to identify it. And another thing to note is sort of, you can see in this cartoon image, these septations between the trunks. So at the periclavicular levels, as the brachial plexus branches along its course, it is associated with epineural sheath division, so they can separate the trunks, the cords, and further beyond in sort of these fascial tunnels. So what that implies is that you, to get an ideal spread, you really should be performing multiple injections. So generally, we tend to sort of deposit 2/3 of the amount of local anesthetic that we normally are targeting in this corner pocket to target the inferior trunk, and then reposition our needle to sort of capture the space between the superior and middle trunks as well. And so for that reason, and also for the fact that they're so tightly bound, it may carry a higher risk of nerve injury than, say, an intraclavicular block. So this particular video is, it's not the most clear image of the brachial plexus, but there's your artery there. You can see the pleura deep and the first rib sort of positioned appropriately underneath the artery. And the needle is targeting this corner pocket. And so the operator is using careful dissection or hydrolocation to sort of create a space that they can subsequently continue to move their needle into until they reach that desired corner pocket. And administration of the local anesthetic there, as you can see, causes sort of the brachial plexus to peel off of that first rib. So it's really nicely shown here. So once about 2/3 of the local anesthetic that you plan to deposit is delivered there, the needle is withdrawn to target the space between the superior and middle trunks. And if you are able to, using hydrodissection, as you approach the nervous structures, can help sort of guide your way into that connective tissue and allow you to stay a safe distance away from the fascicles, obviously. And so you can sort of see this linear spread throughout the brachial plexus sheath, which is reassuring that you're not injecting. You're injecting it in between and not within the nervous structures. This is another sort of video of the same approach. So the needle is coming in pretty shallow from the lateral side. In this case, there's muscle here, so there's lots of room for the needle to move. And once you get closer to the plexus, they hydrodissect to carefully get into that corner pocket. And you can see the brachial plexus peeling off of the first rib there. And in this particular video, they take a more sort of conservative approach, and instead of depositing local anesthetic between the trunks, they deposit the remainder of the local anesthetic above the brachial plexus, sort of bathing the entire thing in local anesthetic as one, as you can see there. And this approach does reduce the risk of nerve injury theoretically, and it will provide analgesic benefit, and possibly, given adequate soak time, will have good block density as well, but they may not achieve surgical anesthesia to the same degree because of those septations that we talked about. So the final block that we're going to talk about is the infraclavicular brachial plexus block, which targets the cords of the brachial plexus that are positioned around the axillary artery, deep to the two pec muscles, the pec major and pec minor muscles. The structures are usually identified at a depth of about 3 to 5 centimeters in the average patient. And with proper technique, it's essentially interchangeable in coverage and efficacy with a supraclavicular block. So whichever block you choose will sort of depend on patient factors, on personal preference, and on some of the consideration of the other associated risks and adverse effects. So again, same indication, upper extremity surgery distal to the shoulder. Some of the advantages, it is fairly easy to recognize the SONA anatomy. It's essentially a perivascular injection around the axillary artery, which we'll see are in sort of 2 distinct compartments. And even though you are depositing local anesthetic in different locations around the axillary artery, you can achieve it with just one needle pass. So it does have minimal needle redirection as compared to a supraclavicular block. The risk of phrenic nerve block is much lower compared to blocks of the clavicle. So highest of the interscalene, about 50% of the time, the phrenic nerve is blocked with a supraclavicular nerve, and far lower risk with an infraclavicular nerve. So it may be more suitable in patients with respiratory compromise. The pleura is a safe distance away from the neurovascular target, so it can be visualized easily. And as long as you know where it is in relation to your needle trajectory, there is minimal risk of pneumothorax. And it's a better place for continuous brachial plexus catheter because of sort of the pec major and pec minor keeping the catheter in place. There's a much lower risk of catheter dislodgement. In terms of some of the limitations, in certain patients with a thicker chest wall, or when you have the target deeper than 5 or 6 centimeters, it can make visualization quite difficult with a linear array probe. There are ways around that. It is possible to use a curvilinear probe to optimize your image in that case, or abducting the arm, as we'll show in the next slide, can bring the structures a bit closer to the surface. It is not really a compressible area, so coagulopathy would be relatively contraindicated for this particular block. It does not anesthetize or immobilize the shoulder, and so because the suprascapular nerve is not blocked with this technique, so patients can still abduct their arm during surgery, and that sometimes becomes a bit of a nuisance for some surgeons during elbow surgery when they find that the patient kind of is able to move their shoulder. But I find that it's really mostly a surgeon preference, and most surgeons are okay with that. And again, just with any other block, there is sort of the potential presence of vessels in the needle path, and sometimes they're arranged in such a way that an infraclavicular approach would not be ideal, but it's important to recognize where those vessels are. Positioning would be the same as a supraclavicular block. The arm can be either situated by the patient, or it can be abducted 90 degrees with the elbow flex. As you can see here, the arm abduction does raise the clavicle, and it sort of reduces the depth from the skin to your target structures. Alternatively, you can use a curvilinear probe in bigger patients. As you can see, the ultrasound is placed in a parasagittal orientation, just medial to the coracoid process, which is marked here, and inferior to the clavicle. The needle is trajectories from cephalad to caudad. And scanning medially and laterally allows you to locate the pleura. Generally, because it's a deeper structure, we do use a lower frequency linear array probe and an 80 millimeter echogenic block needle as opposed to a 50 millimeter. And the typical volumes are about 20 to 30 milliliters of local anesthetic. So in terms of where you sort of position yourself as an operator, there are a couple of options. One is to stand at the head of the bed with the ultrasound machine on the ipsilateral side. And here you can have your needle beam alignment might be a bit easier, and you can use the same hand for needling no matter which side you decide to stand on or which side of the patient you're blocking. The alternative way, which I personally prefer, is to stand on the same side as you're blocking with the ultrasound machine across from you. In this case, the needle is passed perpendicular to your line of sight, and depending on which side you're blocking, you may have to use your non-dominant hand. Just a quick sort of tip that heel toeing the probe so that the beam is angled more towards the head can help visualize your needle when it's difficult to visualize. It only changes the angle by a very small margin, but it does really help to improve visualization of your needle. So what are we aiming to see on ultrasound in this intraclavicular space? So the goal is to visualize the axillary arteries, you can see here, deep to the pectoralis major and pectoralis minor muscles, with the cords of the brachial plexus in their sort of respective positions around the artery. And in this particular case, you can see the axillary vein and an additional vessel that you'd have to be aware of. And it's important to know, sort of to understand how the anatomy of the brachial plexus varies along its course in this area when you're scanning for an image. So above the clavicle, as you can see, and just below the clavicle, the brachial plexus is pretty packed tightly together, just lateral to the artery. So if the proximal portion of the intraclavicular sort of brachial plexus is imaged, which corresponds to a more medial placement of your ultrasound probe, you're going to see your cords clustered cranially to the axillary artery, and there's going to be not much space between the artery and the vein. And as the plexus courses more distally, which corresponds to your ultrasound probe moving more laterally, the cords start to separate and they spiral around the artery into their respective positions, which they're named for, so the lateral, posterior, and medial cord in relation to the artery. So to show that a little bit more clearly here, as you can see, image A corresponds to a more medial placement of the ultrasound probe in that intraclavicular fossa. So that captures the brachial plexus in a relatively proximal in its course. So you can see that the cords of the brachial plexus here are sort of clustered cranially to the artery. And there's really not that much space between the axillary artery and the vein. And as you start to scan more laterally, which is sort of reflected in B and C, and corresponds to more scanning as the brachial plexus moves distally, you can see that the cords are moving into their respective positions around the axillary artery. So in yellow here is the posterior cord, you have the medial cord here in purple, and then the lateral cord in red. And you can see that they're situated around the artery. And that's really kind of where you want to aim for a classic intraclavicular block. You want to be lateral with the cords sort of spiraled around the artery. And sorry, I know I'm running a bit over time. We're just in our last few slides here. But one sort of important thing to note when looking for spread in this area is that the brachial plexus is divided into sort of two fascial compartments. This image here on the left is a post-injection image that helps us visualize these compartments. And so you can see the lateral cord contained within its own compartment. And deep to that, you can see the medial cord and the posterior cord, and they seem to share sort of a larger compartment. And in order to achieve a successful block, you do need to deposit local anesthetic in both compartments. Oftentimes we see the medial cord located between the artery and the vein, and the posterior cord a bit more closer to the 6 o'clock position, but they're still going to be located within the same compartment. So injection at the 6 o'clock position that we're sort of classically taught to target should adequately cover both your posterior cord and spread medially to your medial cord as well. And in most patients, you can achieve this with one needle pass, depending on sort of how well you can visualize the anatomy. So the first target would be to ultimately get into the 6 o'clock position. And the way that you would more easily do that is from the sort of cephalad aspect. Your needle trajectory is going to be tangential to the lateral cord or posterior to it. You can deposit a little bit of local anesthetic here to sort of push the lateral cord out of the way, as you can see here, flatten out your needle and pierce through that second compartment into the 6 o'clock space. The sort of total target volume would be about 20 to 30 cc's. Again, we would deposit about 2/3 of that here and then withdraw the needle, aiming to have it just beside the lateral cord and deposit the rest of the local anesthetic there. So you are depositing local anesthetic into two different compartments, but you are technically able to achieve it with one pass. I'll show you a couple of videos in the last two slides that show that in real time, but just want to make a note that it's important to obviously to reduce the risk of potential trauma to the lateral cord when you're trying to get to that 6 o'clock position. So you can see here that before the needle is pierced through that fascia, you can sort of gently push against the fascia before you poke through it. Make sure the lateral cord is rolling away from your needle to make sure that you're not going to be poking right into it. So again, axillary artery and vein, pec major, pec minor, you have your needle coming in cephalad and targeting that 6 o'clock position with that two compartment technique. So as you see the needle approaching the area, you can see where your lateral cord probably is. The needle is going to be passed tangential to that. A few pokes, seeing the lateral cord roll away. Here they've injected a little bit of local anesthetic, which you can see has moved the lateral cord out of the way. And the needle trajectory continues into that posterior cord. And you can see that spread beautifully sort of in the 6 o'clock position. And if you notice, you can see it spreading medially as well. So before the injection, there really wasn't a whole lot of room between the axillary vein and artery. And now you can see that space is widening. So you can see local anesthetic spread capturing the medial and the posterior cord. And once about 2/3 of the local anesthetic is deposited there, the needle is withdrawn just next to the lateral cord there. That injection is not quite there, so they pull it out a little bit further, and you can see further local anesthetic surrounding the lateral cord. And finally, I just wanted to show you another sort of alternative needle trajectory. Again, you have your axillary artery. You can have your posterior, medial, and lateral cords. And in this case, sometimes, I'll just pause it there. Sometimes if a lateral cord sort of seems to take up too much room, thinking about passing posterior to that and then flattening out your needle could cause you to get stuck on the clavicle and may not be very easy. So in this case, they've chosen to sort of hydrodissect and peel the lateral cord away from the axillary artery and take a more direct approach to that 6 o'clock position. You can see the lateral cord rolling away safely from the needle there. And local anesthetic spread, both medially and posteriorly. So that was a fast-paced review of some of the brachial plexus blocks. I didn't go through any sort of isolated peripheral nerve blocks, one because of time, and also because generally for surgical indications, surgeons will often use tourniquets, and so they will require sort of a full block of the arm. But obviously those are options as well. So we sort of briefly talked about the anatomy of the brachial plexus and the innervation of the upper limb, discussed the sonoanatomy and block technique of the interscalene supraclavicular and infraclavicular blocks, and some indications and advantages and limitations along the way. Thank you very much.